Welcome again to Justice in Scrubs. I'm attorney Richard Hastings, and I'm here with my co-host,
Dr. Jeff Michaelis.
And today we're going to talk about annual physicals and the tests that you take while you are there and what you do to prepare for one. Before we dive in, it's important to remember that the information we provide is for informational purposes only. Every situation is unique, and decisions regarding your health or legal matters should be made after consulting with your own doctor or lawyer. Our aim is to inform and empower, but personal circumstances require personalized advice. We'd like to take a moment to thank our sponsor, findagreatattorney.com. If you or a loved one has been injured in an accident, finding the right lawyer can make all the difference in getting the compensation and support you deserve. That's where findagreatattorney.com comes in. They're a free lawyer referral service that connects accident and injury victims with the best attorneys in their area. With findagreatattorney.com, you can be confident that you're getting a highly qualified and experienced lawyer who will fight for your rights. The best part? Their service is completely free. So you have nothing to lose and everything to gain. If you're in need of legal assistance, head over to findagreatattorney.com and let them help you find one of the best lawyers in your area for your case.
Thank you for having me here today.
Well, you're the co-host, so I'd have to have you here whether you're talking or not. So we're going to talk today about annual physicals and what you should do to prepare. And amazingly, today is the day that I had my annual physical. And I used a lot of the information that you had given me to prepare for my physical. And it's one of those things, I think, for many people that there is some level of anxiety when you have a physical. And I don't know what it's caused by. The fact that, if something's wrong with you, you don't really want to find out about it. But if you don't go to the physical and there is something wrong with you and you don't find out about it, then you kind of make the problem worse. And it's this weird kind of dynamic that at least I go through and I think other people go through, because I know friends of mine that haven't gone in for a physical for 5 years and they're at an age where they should be going in much more frequently.
Yeah, so on a personal note, I had a physical a couple of months ago, and the doctor found something on my face that he was concerned about. And I had a biopsy today. And
that's not just a prop?
And it came back that it's a precancerous lesion. So if I did nothing, and if I ignored, like your friends don't go to physicals, that would have been a melanoma in probably 6 months or a year. And a melanoma is a dangerous skin cancer. So physicals do work. And that's the idea. The idea of a physical is to catch things when they're treatable.
So why don't we jump into it and start with the basics? What should people do? Well, let's even before that. We're talking about annual physicals, but certainly people should be having a general physical annually. Is that correct?
Yes.
And why is that?
So an annual physical basically has 3 goals. The first goal is to get the medicine list proper, like we talked about in the first episode. The medicine list sounds simple, right? Just get a list of medicines. But nowadays, patients go to multiple different doctors and they get medicines from different doctors, and they might be on a different computer system. So the primary care physician probably does not have an accurate medication list. And as we talked about with the elderly, the number one cause of preventable elderly issues is not taking your medicines properly. So the medication list is crucial. And you should not just bring in a list, because you might get a list from Dr. A, another list from Dr. B, because they're only addressing their medicines. You want the whole list properly. So you bring in the pills. And you don't just bring in the pills, you bring in the pill bottle.
Well, let me just stop you, because you had given me this information, and what I did this morning before I went in to see my doctor is I took my pill bottles and I put them on the shelf, and then I took a picture of them with my cell phone. So when I went in and they wanted to know what are you taking and what dosage, I just brought the picture up on my cell phone and I wrote down exactly what the medication was and exactly what the dosage is.
That's fine. If you do it that way, it might make it easier actually than bringing the bags. But traditionally, we used to tell people to put it in a brown bag and bring it to the office. But just don't bring in pills. You know, like years ago, the patients would say, I'm taking a yellow pill. A yellow pill doesn't mean anything to me because each manufacturer makes a different color pill for the same medicine. So we need either a picture or the bottle of pills. Really, really important.
So they're going to bring in their prescription medication list. Talk about SureScripts. What is that?
So SureScripts is a cloud-based pharmacy data, and it stores all the pharmacy data. But it doesn't get 100% of the prescriptions because if you pay cash, it doesn't go up to the cloud. If certain coupons you use to pay for your medicine outside of insurance, it might not go to the cloud. So yes, it might be 95% accurate from SureScripts. It might be 75% accurate, but we need it 100% accurate. We cannot miss any medication.
So what's interesting about that is one of the things my doctor said to me today is I have an ongoing sinus issue. So he was going to prescribe an antibiotic for me. And he said to me, when you take this antibiotic, you cannot take this statin that you're currently taking right now at the same time. So if the doctor didn't know that you were taking a statin and prescribed an antibiotic, that would create a challenge, would it not?
Well, not only a challenge, that can cause an arrhythmia. He's talking about a macrolide with a statin can cause an arrhythmia, an extra heartbeat, which you can pass out from. So it's not just a minor problem, it could be a major problem. So, and if we don't have the information, we don't know. So, and also, the medication list is important. Let's say you have an accident and you end up in the emergency room. They'll have access to my medication list, and if the list is not accurate, it is so important to get that medication list. So the annual physical is a great time to reconcile your medications.
And then what other things should a person do to prepare for their physical?
Right. So, see, the computer systems are not perfect. So another thing they should do is bring in all your test results. So let's say you had a colonoscopy last year or you had a mammogram 5 years ago. If you have access to any of your test results, bring them in. Now, nowadays, doctors have portals where you can just print your results. So, and I might not have access to your portal of your gynecologist. Well, you don't have a gynecologist, I hope.
No, I don't.
Okay, good. Good answer. So, but you might have a GI doctor who has a colonoscopy. So I might not have access to that because that GI doctor might be on a different computer system. So bring in all the tests. And nowadays, patients frequently get their vaccines from pharmacies. We do not have access to pharmacy data in reference to vaccines. That's a totally separate computer system. So vaccines, blood tests, radiology tests, colonoscopies, bring everything that you have in, because what happens is the computer will check, will do what's recommended. So the computer takes your age, your gender, and your medical problems and recommends a list of tests that you're supposed to have. And then it compares to the tests that you actually have had. So recommended tests versus actual tests.
So why don't we jump into, you go to your physical, so what tests are typically ordered during a complete physical?
Okay. So we do a blood test. So we usually do a CBC, which is a complete blood count. And we check your red count, which is your blood count. We check your white count, which can affect it could affect infections, and a platelet count, which checks your bleeding. And that gives us a tremendous amount of information. Specifically, if your red count is a little low, you could be bleeding internally somewhere that we might catch something. So CBC is an incredibly important test. Another test.
And if your white blood count is high, that means?
It means you might have an infection, or you might have even a precancerous lesion or something like that. So,
and then what about a platelet count? What would that show?
Platelet count might show that you have a bleeding disorder, like an early bleeding disorder. So these are really important tests.
So if you have a blood test and the doctor doesn't see you physically, they can look at that blood test and generally determine whether or not you have something wrong with you?
It gives us a clue.
Okay.
And then we might go on to have more tests, but it's a very accurate, very helpful test.
Okay. So what other tests?
So a urine analysis is very important because especially men who have a history of smoking and drinking and might work in manufacturing, they have a high incidence of having bladder polyps. And a urine analysis will show some blood in the urine, microscopic blood. And that might give us a clue that you might have a bladder polyp. Now, a bladder polyp is treatable. You just take it out, sort of like a colonoscopy. You take out a colon polyp. But if you wait too long, it becomes bladder cancer, which is a very difficult cancer to treat. So a simple urine analysis might pick up a precancerous lesion in your bladder. And we also do a liver test and a chemistry test. It gives us some clues on what's going on.
What about PSA?
A PSA is a very important test. So PSA is a prostate-specific antigen. And the prostate-specific antigen is made by normal prostate tests, normal prostate cells, and prostate cancer cells. But the prostate cancer cells make more PSA than the normal cells. So a patient with prostate cancer probably will have a higher level of PSA. Now, the absolute number is not that important. What's important is the change. Prostate cancer cells grow, and they'll make more PSA. So if your PSA is borderline, like 4, I might say, let's repeat it in 3 months. And if it goes down to 3.6, I'm not worried about it. But if it goes to 4.8 or 5 in 3 months, then that might give us a clue. So it's a very helpful test that can give us early diagnosis of prostate cancer.
Or if it's 2 1 year, and then the next year it's a 6 or a 7.
Very important.
That's a big change.
Big change, yes. You're allowed to grow. It's allowed to increase by 20% a year. So if you have 3 and you go to 3.6, that's okay. Or if you have 4, you go to 4.8, that's okay. 20% a year is okay.
What about osteoporosis screening?
Yes. So
what is it and what does it check for?
Right. So it's a bone density test. It checks your bone density. Now, women have, when they go through menopause, they lose estrogen. Estrogen supports your bones, especially in women. So there's a natural progression of bone loss as women age, and that can cause fractures. And fractures are not only painful, but it can lead to lots of medical problems. You can develop pneumonia. You can develop a lot of issues. So osteoporosis is we like to know if patients are developing osteoporosis because we have medication. We have medication that it can increase your bone density.
And then we were talking earlier about colonoscopies. Why is that important to have a colonoscopy?
Okay, nobody should die of colon cancer anymore because colonoscopy not only diagnoses early cancers or polyps, but they can take out the polyp during the colonoscopy without surgery. They can just go in and take it out. It's amazing. And that polyp, some polyps can transform into cancer.
So my understanding is not every polyp is cancerous, but anytime you have cancer, it has to grow in a polyp.
That's very well put, lawyer.
Well, thank you.
Yeah.
I read books and watch videos.
Let me just talk about that a little bit.
Okay.
So there's 2 types of polyps. There's basically 2 types of polyps. There's a hyperplastic polyp that does not transform into cancer. And then there's an adenomatous polyp that does. So if you have a hyperplastic polyp, we're not that concerned. But if you have an adenomatous polyp, I might tell you to have your colonoscopy in 3 to 5 years instead of 10 years. So it's important to know. So
can they tell that visually, or do they have to run some type of lab test?
Great. I was just going to say yes. So it's a pathology test. You cannot tell visually. So it has to be a pathology test. Now, when you get me your colonoscopy results, you should also get the biopsy results. Because the colonoscopy itself, when you're getting me the test that I need for your physical, you should also always ask for the biopsy results because they're 2 separate results. So the GI doctor does the colonoscopy, visually looks at it, and then he takes a piece, or she takes a piece of it, and sends it to the pathologist. So these are 2 separate reports. So when you get a colonoscopy, always ask for your biopsy results.
And then generally speaking, As last you recall, what's the protocol for when you first get a colonoscopy?
Right. So right now, it used to be 50. Now they lowered it to 45 because we're seeing more and more young people with cancer, with colon cancer. Now, if you have a family history of colon cancer, what you do is you take the age that they were diagnosed and minus 10. So if your father or brother or sister had colon cancer at 50, you should start screening at 40.
So I have friends of mine that have never had a colonoscopy. And they're so put off by the whole thought of it, the process, the prep, that to me, it is just inconceivable that you would let those things get in the way of a test that in a great number of cases would eradicate any type of chance of having colon cancer. So maybe we could just talk about, the prep for that, because I've had maybe 3 of them, and I didn't feel, the worst part for me was not eating for 24 hours. So as soon as that clock starts, I'm like ravenously hungry. And then when I'm about 8 hours into it, I'm thinking about calling my doctor's office and rescheduling because I want to eat something.
Right.
But once you go a certain amount of time, it becomes easier and easier. So you don't eat anything for 24 hours.
Right. And 24 hours before that, you would do a liquid diet.
And then what you do is you have this prep where you drink half of it maybe 12 hours before your test, and then the other half of it maybe 6 hours before your test. And that literally just flushes anything out of your system so that, when they go in to do the test, they put the camera in and they can see whatever they need to see.
Right. And I always tell people, buy a book or read a book, because you're going to be on the toilet all night. So just sit there and read. That's what I did when I had my colonoscopy. I read a whole book. So, and also during the procedure, you're given medication. You're just asleep.
Right.
You have no idea what's going on. And I remember when waking up from the colonoscopy that people were handing me like raisin bread or something like that. So you have no recollection at all. So during the test is fine. There's no problem at all. The prep is not the greatest thing in the world, but hey.
Beats getting colon cancer.
Right. And colon cancer is one of the leading causes of death in the United States. It's ridiculous.
And it's preventable.
Totally. Well, nothing's 100%, but it's pretty close to 95, 99% preventable, yes.
And then the first time I had mine, they said everything's fine. I thought, oh my God, that's so wonderful. The second time they said we removed 3 polyps. And we'll know the results in a week or something. And right away, your monkey brain starts going, oh my God, I have cancer. But then you go in for a shorter period of time for return. If you don't have any polyps, you wait a longer period of time. If you have polyps, you have to come in on a more frequent basis.
Let's talk about that.
Okay.
So if you have no polyps at all, it's a 10-year wait. And then if you have adenomatous polyp, which is the polyp that can turn into cancer, it's 3 to 5 years depending on the size. So 3 to 5 years depending on the size of the polyp. And then if you have a hyperplastic polyp, it's usually about 7 to 10 years. So, and they can tell right away if it's cancer because the cancers are bigger. But they can't tell the difference between adenomatous and a hyperplastic polyp. So if they tell you that they removed 3 polyps and they don't say anything bad, it's likely that it's not cancerous, but it could be precancerous.
So let's talk about another type of physical, which I find to be quite fascinating, and that is an executive physical. And what is that, and what additional tests would you have in an executive physical?
So executive physical started when the CEOs of companies were given extra tests. And so high net worth earners were sent somewhere for a full day of testing. And that's why they call it an executive physical. Now, nowadays, there are more of these executive physicals that are geared towards us, not these CEOs. Mm-hmm. So what tests they do is they usually do the Gallery test. The Gallery test is a blood test that can look into 50 different types of cancers.
Wow.
Yeah. So now all the cells in your body, what they do is they leak protein, right? And if the cancer cells leak different types of protein than regular normal cells. And also these Gallery tests is AI machine learning testing.
Really?
So it's just going to get better and better and better. Now, it might come one day. Right now, it doesn't, but it might tell you. We might tell you that you don't need your colonoscopy in the future. Right now, it's not there yet, but these tests are just going to get better and better as they get more samples, as they learn about more things. So the Gallery test, Galleri, is, I think, a very important test you might consider. The only problem is the insurance company does not pay for it, and it's around $900 to $1,000.
Is that a blood test?
It's a blood test.
Okay.
Yes.
What about genetic testing? What does that do? We wanted to take a quick break to remind you about our sponsor, findagreatattorney.com. Dealing with the aftermath of an accident or injury can be overwhelming. And the last thing you want to worry about is finding the right lawyer. Findagreatattorney.com simplifies the process by connecting you with one of the top attorneys in your area who specializes in your specific type of case. Whether you've been injured in a car accident, suffered a slip and fall, or experienced medical malpractice, findagreatattorney.com has a network of experienced lawyers ready to help. And remember, their service is completely free, so you can focus on your recovery without worrying about the cost of legal representation. If you or someone you know needs legal assistance, don't hesitate to visit findagreatattorney.com and let them match you with one of the best lawyers in your area for your needs.
Yes, so the genetic testing is sort of looking to your future, because your genetics determines your problems, your potential problems. Because the way it works is you have genetic code that's geared towards disease. And right now, it's turned off if you don't have the disease. And something will stimulate it to turn on. So the genetic testing will tell us what potential risks we have or what we can have in the future. So, and it might tell you, I'll give you an example, okay? So women who have a high incidence of breast cancer in the family, there's a genetic testing called the BRCA gene. The BRCA gene tells you that you have a higher incidence of developing breast cancer or ovarian cancer. So some women who have a positive family history, who have a positive BRCA gene, they might get prophylactic bilateral mastectomies.
Wow.
Yeah. Because it's, obviously that's a big deal and it's a big discussion, but it's something to think about. So let's talk about the genetic testing. So I get, if you have the marker for breast cancer, one of the options you have is to have a bilateral mastectomy. What would be a genetic test that might show something else that you might not be able to do anything about? And then why would you want to know that? Right. So there's a whole bunch of ethical issues and psychological issues. So usually when you get genetic testing, it's done by a geneticist who will then, talk to you first about it and tell you, why we're doing this test. Because you might, like you said, you might not want to know the answer, but some people want to know. So it's very important, if you're going to get genetic testing, to sit down with either your primary care doctor or a geneticist to talk about the ramifications of the genetic testing. Because you might end up finding things you don't want to know about and that you can't fix. Right. And then they would just cause you to, I'm the kind of person that if I watch some medical show on television, they talk about some kind of pain in your stomach that might be stomach cancer. It's like all of a sudden I'm thinking, well, I kind of feel like I've had that pain. So you're a little bit of hypochondriac. Well, not a hypochondriac so much as that I'm, I guess, prone to suggestion maybe, but I don't know why you would want to find out perhaps you're predisposed to have pancreatic cancer. Right. And then once they tell you that, I think all you're going to worry about is, oh my God, I'm going to die of pancreatic cancer. Yeah, so the reason why you might want to do genetic testing, if you have a very strong family history of some certain cancers that can possibly be treated early. So, and obviously the one that we talk about the most is breast cancer, because the BRCA gene can tell you that you might have it, and we can do something about it. But it's an issue. The genetic testing is not clear. It's not black and white. There's a lot of gray areas to this, and I would urge you to discuss it with a doctor or a geneticist before you have the testing.
And is a geneticist a medical doctor or a PhD?
It's usually a PhD.
What about a heart calcium score? What does that show?
Yes. So when your body gets injured, especially when you get older, it heals with calcium. So it tells us, it gives us a hint if the arteries have been injured. So if your calcium score is 0, you likely do not have any blockages in the arteries in your heart. If the calcium score is 300, then there's a concern that you might have blockages. So it gives us a hint on what's going on. And if you have a high calcium score, you're more, let's say your cholesterol is borderline, right?
Mm-hmm.
And you have a high calcium score, I might treat you sooner because of the additional data of an abnormal calcium score. So it gives us some hints.
What about a full body MRI?
Yeah. Once again, the problem with a full body MRI is we might find things that we're not sure, like a little ditzel or a little growth. And we might tell you, we don't think it's anything, but it might be something. And we're going to have to repeat it in 3 months or 6 months. And, imagine if I tell you that you might have something in 3 months, you might have something, and you got to wait 3 months.
So a friend of mine went to the doctor and they had a problem. And the doctor said to my friend, this could be anything from the common cold to leukemia. So when that person left the office, what do you think they thought they had? Right. Common cold or leukemia?
Right.
And I talked to this person and they said, oh my God, I think I have leukemia. I mean, I don't know why you would want to know maybe woulda, coulda, shoulda if there isn't anything that can be done. It's like if you found a book that said the day you're going to die, would you open it up and read it? I would not.
Right. So, everybody's different, right? That's why you should have a discussion with a professional, because, that's why you don't want to go to genetics.com and get a test there, because you got to discuss it with them, because we're not sure. It's like a Pandora's box. You might be opening something that you really don't want to open.
Right. Yeah. Let's talk about the Medicare annual physicals and how they are different.
Yeah, they're very different. The purpose of the annual physical for Medicare patients is to figure out if they're safe where they are, whether they should be at home still, whether they should be living with a family member, whether they should be in assisted living. So the way it works is we send the patients a questionnaire. And the questionnaire discusses basically ADLs, which is activities of daily living, to make sure that you can handle the activities of daily living. And then when you come to the office, we do a memory test, we do a mobility test, we do these tests to see if the patient is safe. Mm-hmm. And so that's the key. So remember, a normal annual physical, you're worrying about the medications, the health screening, and that kind of thing. But for the Medicare annual wellness, you're worried about safety. And it's a very, very different exam. And it's a very helpful exam.
So what is the goal or idea behind an annual wellness examination?
Right. So just like I had mine. So they discovered a pre-malignant skin cancer. So if the idea is to get it before it gets you. So unfortunately, cancer is very, very common, and we want to diagnose it early, because most of the time it's 100% curable if you diagnose it early.
And what I find fascinating is, growing up, I don't remember hearing about many people who either had cancer or died of cancer. And nowadays, it seems like everybody knows somebody that either has a family member or a friend that has had cancer or has died of cancer.
So there's two reasons for that. One is that the older generation, they didn't talk about things, right? So when I went into practice in the 80s, a lot of family members, when I told the family member that their parents have cancer, they would say, "Don't tell him. oh, don't tell her, because they won't be able to handle it. So a lot of this stuff was pushed under the rug. But also, people are living longer now. So ultimately, we're all going to die. So, and a lot of times, unfortunately, the death is cancer. So because of the longevity, increased longevity, we're seeing more and more cancer. Whether it's because of environmental changes, stuff, I don't know. But I think it has to do with that we're much more open about our illnesses nowadays, and also that people are living longer.
And I have another friend of mine that went in with his father to the doctor. His father was in his mid-80s. And the doctor said, you know, I have some good news and I have some bad news. And the bad news is you have cancer. And the older man said, what's the good news? And he said, you're not going to die of cancer.
Right. That's a great point. And that's typically for men is prostate cancer.
Mm-hmm.
So there's a lot of controversy whether we should treat prostate cancer because patients wouldn't have died of the prostate cancer. So the way I look at prostate cancer is there's two illnesses. You have prostate cancer in men in their 50s, and then you have prostate cancer in men in the 70s and 80s. So if you develop prostate cancer in the 70s and 80s, you really need to look at the whole picture, because if the patient is not going to live for 10 years because of heart disease or diabetes or some other illness, you might not really want to treat the prostate cancer. But if you're a 50-year-old man and you're diagnosed with prostate cancer, you need to treat that. So, and actually the natural history of prostate cancer usually when it's diagnosed in the 50s is a little bit of a more aggressive cancer than the prostate cancer in the 70s. It was more indolent.
Mm-hmm.
And actually, if you do an autopsy study of 90-year-old men, 70% of them have a little bit of prostate cancer in it. But they didn't die of prostate cancer. They died of something else. So that's a really good point. So that's why, there's not, you got to treat everybody individually, because you got to look at the whole picture. You got to look at their other medical issues. And if someone's perfectly healthy, right, and they're 82 years old, you might treat that prostate cancer. But if you have a 62-year-old with end-stage heart disease, you're not going to touch it. So the age alone is not the right answer. It's their medical history and their medical conditions.
That's a great point. Are there any other tests that should be ordered as a part of a comprehensive physical exam? So
sometimes we do a thyroid function test, TSH.
And what does that show?
Well, the thyroid is really thyroid controls your metabolism. It controls your energy. It's basically a control system of your body. And it's very common that the thyroid sort of peters out as you get older. Thyroid just gets old. And if the thyroid's old, if the thyroid is not functioning well, you want to replace it with pills that we have. And you can feel a hell of a lot better if you take the pills. So it's a simple blood test, and I think it's very helpful. Also, the vitamin D test is very important for women because vitamin D helps the absorption of calcium, and the calcium then helps your bones. So women that have osteoporosis or osteopenia, which is borderline bone density loss, the vitamin D level is important because if it's low, it needs to be treated.
So does most osteoporosis occur with women, or do men also suffer from osteoporosis?
Yes. So yes, most commonly it's women.
Because of the lack of estrogen.
Yes. But then you do see some osteoporosis with men. Typically it's because they took steroids or some other medical condition. But also if men have low testosterone, they can have osteoporosis too. So all women should be tested with bone densities. But men who have fractures, especially if you have a non-traumatic fracture, or if you fell and didn't fall from really high, you just had a little trip and you have a fracture, that's suggestive of osteoporosis. So a lot of orthopedic groups are doing bone densities on everybody over a certain age that have fractures.
And what do you do for osteoporosis? Is it taking oral calcium pills?
Well, no, it's an oral medication. There's oral medications, and then there's a whole bunch of different things. There's injectables. There's a daily injection. There's a 6-month intravenous, and then there's a lot of different ones, and there's a whole bunch of new ones coming out. So osteoporosis is very, very treatable.
Let's talk about one near and dear to your heart, which is skin cancer screening.
Yes.
Near and dear to your face.
Right. Is my Band-Aid still on?
It is.
Yeah. So, yes, it's a simple. Everybody should see a dermatologist once a year. I would say after the age of 55, especially people who've been in the sun a lot. And what was amazing is when I went to the dermatologist, she had this little polarized lens, and she looked at my face. She said, "Everything's fine, but let's look at these things." And she took pictures of the polarized lens. And what it does is it allows her to see a few layers deeper, a few layers of skin deeper.
Mm-hmm.
And she said to me, "I think it's okay, but why don't you come back in 6 weeks or something?" So, and she took a picture through the scope thing. And then she looked at it again in 6 weeks. She says it's changed.
Really?
Yeah. So then she biopsied it.
Wow.
So,
6 weeks.
Yeah. Isn't that amazing? And also this technology is fantastic. So she said to me that normally, like 5 years ago or 10 years ago, they didn't have these polarized scopes. She said, I would have dismissed it because it really didn't look that bad. But then I was able to look with this special lens, and I was able to look at it, and then I realized, yeah, there's something there. So they have a lot of great technology now for skin.
And like you were saying earlier, if that wasn't caught, if that wasn't treated, I mean, one of the options would have been quite severe.
Yeah, so melanomas is something, there's basically three different types of skin cancer. There's a basal cell that very seldom goes on to cause problems. Then there's a squamous cell, which sometimes goes on to cause problems, but it really takes years to cause it. And you would see it would be big and it would be ulcerating. And then melanomas can be serious even without changes in the periphery. You can have deep melanomas. So melanomas is not something you want to mess around with. And melanomas can cause death.
Can we talk about tests for some common diseases like diabetes?
Yes. So if you have a family history of diabetes, adult onset diabetes, not like the juvenile diabetes where people need injections. If you have a family history of adult onset diabetes, you have a 50% chance of developing diabetes.
Really?
Yeah, 50%. Now, you can have a propensity to develop diabetes, but you might need the environment, and the environment would be weight, right?
Mm-hmm.
So people might have the gene that causes diabetes, but if they're thin and they exercise well and they have a good diet, they might get away with not having diabetes. But so adult onset diabetes, especially if you have a family history, is a simple blood test. You just do a blood sugar. And then if it's borderline, there's more sophisticated testing.
Tell me why your weight would affect triggering adult diabetes.
Right. So the way it works is you have sugar in your blood, and then you have the protein called insulin, right? Everybody knows about insulin.
Right.
Insulin delivers the sugar into the cells. So for some reason, if you're overweight, the insulin sensitivity is decreased. So the insulin doesn't work as well when you're overweight. So actually your insulin level can go higher, but it's less effective if you're weight. So and elevated insulins cause increased appetite, can cause weight gain by itself, and it can cause heart problems. So elevated insulin is not a great thing.
So I have two friends of mine that found out that their children, who are, college age individuals, have juvenile diabetes that just came out.
Right.
So they're 18, 19, 20 years of age, and they find out now that they have juvenile diabetes. How does that occur?
We don't really know. It just happens. There's a lot of theories about it. We think it's immune dysfunction, like autoimmune dysfunction. Their cells are being attacked by your body.
So what's the difference between juvenile diabetes and adult onset of diabetes?
Great question. So juvenile diabetes, usually you have no insulin. Your pancreas doesn't make any insulin.
Oh.
So you have to take supplemental insulin.
And that's where they have the pumps,
Right.
the internal pumps that pump insulin.
There's a whole bunch of new technology.
And then you have to kind of monitor what you're eating, and there's a point system, and then you then push a button and the computer shoots in the right amount of insulin?
Exactly.
Wow.
Yeah. So in adult onset diabetes, there's usually insulin, but it's not as effective. And you can even have an elevated insulin level.
So juvenile diabetes has nothing to do with your age. You could get juvenile diabetes as a 50-year-old?
You can. It's more likely, that's why we call it juvenile diabetes, to get it in the teenage years or college years. Mm-hmm. But you can have adult onset juvenile diabetes. And it's unusual, but we do see it's on occasion where there's no insulin.
So let's talk about stress tests and what you do if there's an abnormal stress test.
Right. So the reason why you would do a stress test if a patient is having symptoms, they're having chest pain with exertion, shortness with exertion, and a stress test can imply that there's blockages in the arteries. So the best way to do that, the gold standard is a catheterization, where they put a little transducer in the artery and they shoot dye up through the transducer, and they actually image the arteries to see if there's blockages. And if there is blockages, they can, through the transducer, they can put a stent in and open it up. So they balloon it open and then they put a stent in, which is a metal stent. And that can actually fix the problem. And they could do it all without surgery.
Okay, so let's talk now about other common tests that you might have. And specifically, let's talk about an X-ray, a CAT scan, and an MRI. Right. What are they? How are they different? And when would you have one over the other?
Right. So an old-fashioned X-ray, looks at the bones, right? So it looks at the calcium of the bones. So if there's an interruption of the bone, there's usually a fracture. It also can image densities. So if you have pneumonia, you have a bunch of inflammation, and the X-ray doesn't go through that as well. So you can compare it to air. Air is black on the X-ray because the beam goes through without it blocking it. Then the pneumonia could be gray. So that's because there's inflammation. So it's a good test for pneumonia. It's a good test for fractures. But the CAT scans and MRIs are a much better test.
So what's the difference between a CAT scan and an MRI? When would you have one and when would you have the other?
Right. So musculoskeletal test is usually an MRI because MRIs really look at the soft tissue better than the CAT scans. So musculoskeletal is usually the MRI because the MRI can pick up a stress fracture, which is a very small fracture that the X-ray might miss. So let's say, for argument's sake, you sprain your ankle, right? Mm-hmm. You turn it and it's all swollen and black and blue. Typically, it should be better in a week or two. If it's not better in a week or two, then you need an MRI to see if there's a stress fracture. Because if it's a stress fracture, the treatment is different. You might have to go in a boot instead, in a boot. And if it's just a sprain, you might actually go for physical therapy to increase the range of motion. So the treatment is totally different with a stress fracture. So typically you do an X-ray for an ankle or a fracture, and if it's not better than in 2 or 3 weeks, then you'll do an MRI.
So one of the things that fascinates me is in my line of work as a personal injury lawyer, we might be contacted by somebody who's been injured in a car accident, and they contact us maybe 6 weeks after the accident. And we find out that they went to the hospital and received some care and treatment and were discharged, and then went to say, for example, they went to a chiropractor. And the chiropractor treated them 2 or 3 times a week for the 6-week period of time without really having the results of an X-ray or a CAT scan or an MRI. And wouldn't it be important to have that information so you know what you should be manipulating and what you should not be manipulating? Absolutely.
Absolutely. And especially because 6 weeks later, if you just repeat the X-ray, you might see healing. Mm-hmm. And if you see healing, that implies there's a fracture. So the most important thing is that response to treatment, right? So if you're getting better, you might not need more imaging. But if you're not better, then you might need either another X-ray, a repeat X-ray, or an MRI. So response to treatment is the important thing.
And the other thing is doctors don't want to have patients, I don't want to say unnecessarily, but imprudently have these tests because they don't want to have them, be exposed to the radiation.
Right.
And they're expensive as well.
Right. And also the insurance company might not pay for it initially. So it's important to just see how the patient responds. If the patient doesn't respond, then you need further testing. If the patients get better, they're better.
So as we're getting to the point where we're going to start to wrap this up, what is your major takeaway that you would like to share with the audience about annual physicals?
Right. They work. Look at my face. They work. I would have had a melanoma.
That's working? Oh, yeah. That's that part.
Yeah, that's a good point. Excellent point.
Maybe biannual physicals.
Yeah, I might need more help. So physicals work. The idea is a general physical or annual physical is to get it before it gets you, right? And also maximize your medication list. And also the wellness, annual wellness, is a check to see if you're safe or you're in the right place.
So thank you, doctor, because this has been very informative. I hope it encourages people to go and have these very, very, very important physicals because, like you said, they could be the difference between life and death, given what might be wrong with you. And the longer you wait, the longer that you certainly run the risk of having something, adverse happen to you.
Right. I know nobody wants to have a colonoscopy, but you do not want to deal with colon cancer. I mean, I have this image of this patient who I really liked. He was a really great guy. He was in his early 50s, and I told him to have a colonoscopy at his 50-year-old. At the time, it was recommended 50. So I told him to have a colonoscopy, and he just didn't do it. He just didn't want to have someone stick something up his, what.
Right.
And he died of colon cancer.
Oh, my God.
And I think it was 53 or 54. Oh. And, he had such a lovely family with kids and his lovely wife. The whole thing was just horrible. And he really, not only did he die, he suffered a lot.
Oh, that's horrible.
So get your colonoscopy.
Mm-hmm.
Yeah. Okay. So, yeah, I think the bottom line is physicals work, these tests work, and the bottom line is early diagnosis is everything.
Mm-hmm.
It's been my pleasure, and I hope this helps you understand the need for physicals. And maybe you'll join us next time, and we'll continue to explore different issues. Now, if you guys have any questions or want us to address any issues, please put comments on our YouTube page or whatever. So we're open to suggestions of what you want us to talk about.
Terrific. Thanks so much.